Good afternoon. This is Jason Jones with the Community Technical Assistance Center, and I would like to thank you and welcome you to today's webinar, Eating Disorders 101, Overview and Treatment Recommendations. Before we get started, I want to take a moment to orient everyone to the WebEx system so you know how to participate in today's event. Please note that upon joining the webinar, you've been placed on mute to avoid any background noises that may distract others from listening to the presentation. If you come across any technical issues during today's event, please chat to the host who will be able to assist you. You will have the opportunity to submit questions for the Q&A portion of today's presentation by utilizing the chat box feature, which is located on the right-hand side of your screen. If it is not visible, click the dialog bubble on the top right toolbar and it should appear. In order to ensure that we're able to answer as many questions as time permits, we are requesting that you send in your questions at any point during the webinar, and we will address them during the Q&A portion of today's presentation. We are very excited to have with us today Amelia Lamb, the psychotherapist and team leader of Renfrew Philadelphia Center City. Once again, thanks for joining us, and I'll now pass it along to Ms. Lamb to get us started.
Hello, everyone. Thank you so much for coming in today. And thank you, Jason, for the introduction. So this is Eating Disorders 101, Overview, Treatment Recommendations. In no way is all of the information on this going to be all of the information you're going to need to know for treating eating disorders. We're going to kind of go over a lot of different topics, but I really appreciate everyone coming out today. So about me, so my name is Amelia Lamb. I'm a licensed clinical social worker in both New York, Pennsylvania, and New Jersey. I'm a psychotherapist and a clinical supervisor in private practice, and right now I am the team leader of the Renfrew Center for Eating Disorders in the Philadelphia Center City site. So I've experienced in outpatient, intensive outpatient, partial hospitalization, and inpatient levels of care for eating disorder treatment. So I've been in every level of care other than residential. I'm a supervisor for social work interns and unlicensed mental health clinicians for eating disorder treatment. And I have a lot of training experience with residents, medical staff, and other auxiliary staff in an eating disorder informed care setting. So just a little disclaimer, the opinions in this presentation are those of mine and not my previous or current employment. So I wanted to get to know everybody else as well. So there is a poll that should be popping up for you guys. So have you ever worked with anyone that has struggled with an eating disorder in a professional setting? And I'll give you guys a minute to answer. Okay, so most people, about half, said that they have worked with somebody who's struggled with an eating disorder. So this is a great opportunity to learn a little bit more, get some treatment recommendations if you have a case that's ongoing. Quite a few people have said that they have not. This can be a really good place to be able to maybe learn some warning signs in case you have future patients who are dealing with this. And a few people were unsure as well. And so this is, again, a great place to be able to learn a little bit more about these diagnoses and the comorbidities that might come with them, so that in future, when and if you have a case, it can be really helpful for that. Okay. So I wanted to talk a little bit about diet culture as a whole. So this is a $60 billion a year industry. However, the content in a lot of these advertisements, about half of them use false or unsubstantiated claims. So we're spending all of this money a year learning about this industry, getting flooded with content, and a lot of it's not even accurate. And if you see this picture on the side, so this is an ad from the early 1900s. where they were recommending that people ingest tapeworms to be able to help with weight loss. So obviously, you know, this ad is no longer something that is publicized, but we are bombarded every day with so many different advertisements and so many different new fad diets, a lot of which don't work, some of which maybe work temporarily, and then as you see, 95% of all dieters regain their lost weight within 1 to 5 years. And dieting is usually found to be associated with greater weight gain and increased rates of binge eating rather than actually decreasing those rates. So, you know, it's a $60 billion a year industry, but we're finding that it's not really something that's long-term substantial. Okay. So according to the National Center of Addiction and Substance Use, I'm not going to necessarily go through every single one of these, but over half of teenage girls and about 30% of teenage boys report trying to lose weight. About, you know, again, over half of those girls and about 30% of those boys are actively dieting, and they're exercising with the goal of losing weight or to avoid gaining weight. That there are 19% of teenage girls and about 8% of teenage boys that fast, many that use diet pills, powders, liquids, and about 8% of girls, 3% of boys vomit or take laxatives to lose weight or, again, avoid gaining weight. So over half of teenage girls and about 1/3 of teenage boys are using unhealthy weight control behaviors like skipping meals, fasting, smoking cigarettes to potentially help curb that appetite, vomiting after eating, or taking laxatives. About half or so, 35 to 57% of adolescent girls use crash diets, fasting, self-induced vomiting, diet pills as a way to help with dieting. And dieting was the most important predictor for these 14 to 15-year-old girls in terms of risk for developing an eating disorder. Okay, so in terms of disordered eating, so again, this doesn't necessarily mean that somebody has a clinical diagnosis for an eating disorder, but perhaps they are having some disordered eating patterns. So it can be skipping meals, taking smaller portions, uncomfortability eating around other people, new practices with foods or fad diets. So it could be, you know, trying the new fad diet every time something seems to be coming out. It could be cutting out entire food groups like no sugar, no carbs, no dairy, switching rapidly over to a vegetarian or a veganism diet, and with the hope that it's to lose weight or prevent themselves from gaining weight rather than if they have some sort of ethical concerns around that. Withdrawing from friends, concern with body size and shape, frequent checking in the mirror for perceived flaws in appearance, and extreme mood swings. So as you can see in this picture here, there's a lot of pictures that are out like this where the way that this person is viewing themselves in the mirror is very different from the way that they look. So we call that body dysmorphia, but basically that frequent checking in the mirror, reflective surfaces, walking down a city street and looking in building windows if they're reflective, a lot of that behavior can potentially be a warning sign. So in general, these behaviors and attitudes are indicative that weight loss, dieting, and control of food are these primary concerns for them. And there's a preoccupation with weight, food, calories. Again, those carbohydrates and fats are things that are definitely things that are cut out first. Refusing to eat certain foods and refusing to eat certain food categories, dieting frequently, and food rituals. So there's a lot of different ones. Some people might have a lot of different food rituals. Some of them maybe just use certain food rituals. So again, eating only a particular food group. So those will usually be, especially for anorexia nervosa, those will usually be the lower calorie food groups. So a lot of vegetables, a lot of fruits, and omitting, those carbs, starches, and fats, things that are higher in calories. Excessive chewing. So along with that, some people count how many times they're chewing as well. Not allowing any foods to touch. So as you can see here, everything's kind of separated out on that plate. And if something were to touch another food item, they would not be eating it. Or food mixing. So it could be, again, it's going to be something that's a little, it's not going to be like a yogurt and a granola or yogurt and fruit. It's going to be a whole lot of things mixed together that wouldn't normally go together. Some other things that people might do is overspice their food, put way too much salt on their food, a lot of hot sauce, to basically make the food eating experience painful and uncomfortable rather than enjoyable. And so a lot of people engage in these behaviors as a way to safely eat food. If they follow these rituals, then they're doing food eating in a safer way. And it is very, very distressing to eat food and not be engaging in these behaviors. So some physical warning signs of disordered eating. So cuts and calluses across the tops of fingers because of induced vomiting, dental problems, dry skin, hair, brittle nails from malnutrition, swelling around the area around the salivary glands. So this is actually something that happens and occurs when somebody stops inducing vomiting for a short period of time. The salivary glands end up swelling. So it kind of gives almost like a chipmunk type of appearance. Lanugo is fine hair all over your body. So it's kind of like that peach fuzz hair, but much thicker, much denser. And basically it's your body's protective way of keeping itself warm. So there's a lot of adaptive ways that your body responds to malnutrition, and that's definitely one of them. So cavities or discoloration in your teeth, muscle weakness, yellow skin. So again, people tend, especially the patients with anorexia nervosa, tend to eat a lot of vegetables. So sometimes they have yellowing skin because of the amount of carrots that they are eating, because they're a lower calorie food. Cold hands or feet, and also swelling of your feet. That's called edema. So basically, it just is water retention, and again, your body's way of protecting itself, adding moisture to these really crucial joints. Poor wound healing and impaired immune function, which obviously is very crucial in a time of a pandemic. So taking care of your body, taking care of your immune system is something that can make a lot of these patients really immunocompromised if they're not getting adequate nutrition. Dizziness, especially when standing up, fainting or syncope, which is another word for fainting, feeling cold all the time, problem sleeping, fluctuations in weight both up and down. So if you're not having consistency with your body, sometimes your weight moves up and down a little bit more rapidly than it would with a constant diet. So sometimes people's weight goes up if they had more to drink that day, meaning water, or alcohol. Sometimes your body the day after drinking, your weight fluctuation your weight can move up quite a bit because your body's retaining water. So that's something we sometimes see. Stomach cramps, other gastrointestinal complaints, menstrual irregularities, so missing periods or only having a period when you're on a hormonal contraceptive. So it's not really that true period that somebody might be having. It's something that is just kind of created by the medication. Difficulties concentrating is a huge one. So a lot of patients that are malnourished sometimes come in with complaints about difficulty concentrating and attention deficit disorders. That might be something to look out for because we find that with consistent nutrition, that difficulty concentrating does dissipate over time. And abnormal lab findings, so anemia or low iron in your blood, low thyroid or hormone levels, low potassium, low white or red blood cell counts. Okay. So the DSM-5 feeding and eating disorders. So I don't want to spend a whole lot of time on each individual diagnosis, just because I really want to spend a lot of time talking about treatment options and ways to help patients that are struggling with this. So just to kind of go over them briefly. So anorexia nervosa is restrictive eating. So to meet that full diagnostic criteria for all of these, obviously it has to have this impairment either with your social life, your work, your school. And so for anorexia nervosa, there are two types. I feel like a lot of times there's a misconception that if somebody is binge eating and purging, they automatically have bulimia, but that's absolutely not the case. The cycle that tends to happen when you're restricting all day is you get very hungry, and sometimes it can lead to binging episodes and then purging episodes after. And again, for purging, that can be self-induced vomiting, which is kind of the most common and also the most kind of publicized. That's what most people think of when they think of some sort of compensatory behavior. But it could also be over-exercising, taking laxatives. There's a lot of other potential ways that somebody might be compensating for the amount of food that they're taking in. And there's no longer a specific weight or BMI requirement for anorexia, but there is an understanding that it needs to be under the weight that would be normal for that person in their life stage. And then there's levels of severity, which are rated by BMI. So mild would be a BMI more than 17, so anything above 17. And then anything below that would be, moderate, severe, and then extreme would be a BMI of 15 or less. Bulimia nervosa, we talked about kind of that different types of compensatory behaviors. But the binging behaviors, it's got to be a period of time that's maybe over a shorter period of time, hiding that eating behavior from people. It could be, again, it's all about kind of this lack of control over this eating episode over this discrete period of time. And then again, engaging in any of these compensatory behaviors. So again, it could be self-induced vomiting, it could be laxatives, diuretics, over-exercising. So it doesn't have to be the self-induced vomiting to be a purging behavior. Binge eating disorder is all of the components of that binge episode without the compensatory behaviors as a result. When we talk about these diagnoses a little bit later on in terms of the Hayes model, health at every size, sometimes people are misdiagnosed with certain behaviors based on stigma around their body size, but we'll get a little bit more into that later. Avoidant restrictive food intake disorder. So this is all of the restrictive aspects of anorexia nervosa without any kind of body image concerns. So we find this mostly with younger kids. We seem to find it more often in boys and young boys, like maybe like the 5 to 14 range. A lot of this has to do with either fear of the texture of different foods, fear of vomiting, fear of choking on certain foods, and so they avoid those foods. And so they can have those physiological and emotional side effects of the eating disorder, but they're not doing it in the hopes to lose weight or the fear of gaining weight. So that's kind of the distinction there. Once there is a fear of gaining weight or a want to lose weight as a result of this restrictive eating, it's no longer avoidant restrictive food intake disorder. Okay. So this kind of gets into a little bit of the kind of different ones that I feel like are a little bit less common, but definitely occur a lot. And sometimes these can occur simultaneously. So pica is the eating of non-food items. So it could be dirt, toilet paper, sand, clay, can be a lot of different things. But it's not something that is associated around any kind of cultural practice, which is important to differentiate. So rumination disorder is when you are regurgitating the food. So you're spitting it out, chewing and spitting, potentially re-swallowing it. Other specified feeding and eating disorders. So this seems to be, in, again, my personal opinion, the most common diagnosis, because so many people don't necessarily fit all of the specific criteria for each one of these diagnoses. So atypical anorexia is somebody who has all of the symptoms of anorexia, but they are above a normal BMI. So that happens for a lot of people. And again, we're there to treat the behaviors. And yes, there are definitely some serious health complications that can come with being underweight, but we don't want people to have to get there. And so treating the anorexia symptoms before somebody reaches a low BMI is really important. Night eating syndrome, so that can be somebody waking up in the middle of the night and eating. Purging disorder, so there's no binging involved with that. So they are eating, not in a way where they feel out of control. It's not a larger portion. They're not hiding it from people, but they're still purging afterwards. And orthorexia is it's kind of it's not an official diagnosis. It's another specified feeding eating disorder. But it is something that is basically about cutting out different food groups. There's a concern about health a lot. So obviously not anyone who is kind of like a health nut would fit into this category. It has to, again, reach a level where it is causing social impairment or impairment in school or occupational functioning. But it's going to be somebody who's restricting certain food types, very preoccupied with weight and exercise, but not necessarily meeting the criteria for anorexia. Diabulimia is when somebody has diabetes and they are intentionally either increasing the food that they're eating that could potentially be altering their blood sugar levels, or neglecting to use their medications in fear that they themselves are going to cause weight gain. And compulsive exercise, again, it's kind of like purging disorder. There's not that binging component, but maybe the compulsive exercising on top of that. An unspecified eating disorder is when somebody does not fit any of these criteria, and maybe you're not really sure what kind of diagnosis they might have, and it's kind of something to put in place while you're trying to figure out more information. So prevalence, about between 0.3 and 0.4% of adolescent and young women and 0.1% of men suffer from anorexia nervosa. The subthreshold is at about 1 to 3%. So again, that subthreshold, that atypical anorexia, that's really prevalent. 1% of young women and 0.1% of young men meet diagnostic criteria for bulimia, and 3.5% of women and 2% of men have binge eating disorder throughout their life. So specifically for these adolescent girls, that they followed them in this longitudinal study, that about 5.2% of the girls met criteria for one of these diagnoses, and that by the age of 20, 13.2%. And when we were talking about our avoidant restrictive food intake disorder, is also called ARFID. So when we're talking about ARFID, 14% of these group of adolescents had this diagnosis. Nearly half of them, it was because of that fear of vomiting or choking, or those, again, the sensory issues, the way that the food tastes in their mouth, the texture of it. And there are quite a few people that have avoidant restrictive food intake disorder that are on the autism spectrum. That's a definite comorbidity there. So co-occurring diagnoses. So with eating disorders, it is rarely, if ever, that is the sole diagnosis. These are emotional disorders, and they generally carry with them some sort of comorbidity. So mood disorders, mostly major depression, that's a really high percent of people that are coming in with an eating disorder. 56% were diagnosed with eating disorders, 20% obsessive compulsive disorders. When we were talking about those food rituals before, that they feel unsafe eating the food without engaging in these food rituals, that is when that diagnosis tends to be really prevalent. Post-traumatic stress disorder. So trauma history is huge in eating disorder treatment. There are so many people that come in with a trauma history. Some might meet diagnostic criteria for PTSD, some might not, and definitely substance use. That is definitely a big one as well. So as I mentioned before, it's an emotional disorder, and the way that you might be engaging in the behavior to try to just, decrease that distress that you're experiencing may be with eating disorder symptoms, and it may be with other type of avoidance strategies, and substance use and alcohol use is definitely up there. So again, in some other studies, 1 in 4 people had symptoms of PTSD. So again, they might not meet full diagnostic criteria, but they definitely had symptoms of it. 2/3 showed signs of an anxiety disorder. And again, those obsessive compulsive traits, perfectionism, following the rules, concern about mistakes, tend to be a comorbidity as well. Okay, so there are a lot of myths about eating disorders. So there is this general misconception that people who struggle with eating disorders are affluent, skinny white girls. That is really what a lot of people, what the media presents as being the people who have eating disorders, particularly anorexia nervosa. But what we are actually finding is that, yes, people from white females, people from an affluent background are generally more likely to get treatment for an eating disorder. That does not necessarily mean that those people are more likely to have one. So about 20 to 30% of people with eating disorder symptoms end up getting treatment. And they do find that any race can have symptoms of these eating disorders, but again, it might be just the access, which we'll kind of get into in a minute. So people of ethnic minorities are less likely to be asked by a provider if they are struggling with an eating disorder, and less likely to be referred to an eating disorder provider for symptoms. So again, in the case, non-white, lower income, higher weight, and non-female identified patients are less likely to get treatment. That is really thought to be due to the stereotypes involved with eating disorders. The more people think, I'm not a skinny, white, affluent girl, I can't really have an eating disorder, the less likely they are to get treatment. But you as providers, it's so important for you to be asking all of your patients about these types of things, because a lot of times the providers, again, are not referring to people that do not fit this mold. So that's where it kind of lands on you. So common barriers, finances, lack of insurance, not being able to believe that others could understand or they could help, fear of being labeled, not being aware of resources, and a lot of feelings of shame or discrimination. So again, these are just overall prevalence of adult mental illness by race. There is no reason to think that eating disorders do not follow the same trend. However, what we're seeing is that people of ethnic minorities, of different races other than white, are not accessing this care. So again, that kind of goes on the providers to be able to recognize these things and to ask about them. Health at every size, or HAES. So this is, so I myself am a HAES provider. You might see, if you are looking at any kind of providers that are specialized in eating disorder treatment, they'll have those letters next to their name, HAES provider. So it is an understanding that a person's genetic inheritance influences their bone structure, their body size, their shape, and their weight differently, and that we should appreciate those differences, encourage healthy behaviors, and treat everybody with respect. And someone's ideal body weight, or IBW, is something that allows you to feel strong, feel energetic, and lead a normal, healthy lifestyle. It can be a range of weights, and that is when a dietitian would really be important to try to figure out what that weight might be for that patient. And so the basic premise for HAES, or Health at Every Size, is that the well-being and healthy habits are more important than the numbers on the scale. So again, we're trying to target those behaviors. How are these behaviors impacting someone's life? How are they leading to these negative behaviors and also these potential side effects, both mental and physical and social, for this person? So we're really just targeting, again, the behaviors, not the weight on a scale. And so many people are misdiagnosed with binge eating disorder when they actually have bulimia nervosa, and or they have more symptoms of anorexia nervosa, but they do not meet that that weight requirement, and they are would fit kind of that atypical anorexia, but because they are of a higher weight, it is taken less seriously. It is not necessarily something that providers will refer to. They will more likely provide referrals to a weight loss program, which is the very problem in itself. So it's kind of encouraging that eating disorder rather than helping to alleviate those symptoms. And just kind of, I'm a dog person, so just kind of a bunch of different pictures of different breeds of dogs. People come in all different shapes and sizes. One person's healthy ideal is going to be very different than somebody else's. And just to remember that it's the behaviors, it's the lifestyle, trying to help someone reach their best self is going to be different from person to person. So for patients, the principles are to accept your size, love and appreciate the body you have, trusting yourself, trusting your body, allowing your body to naturally find the appropriate weight based on your hunger, fullness cues, your appetite, adopting these healthy lifestyles, and finding joy in moving your body. So we call this joyful movement. It's not exercise for the goal to lose weight. It's, I really enjoy going for a hike, so I want to go and move my body because I enjoy it, and it's a enjoyable activity for me. Eating when you're hungry, stopping when you're full. Again, this takes a lot of time to be able to recognize these hunger and fullness cues for yourself. If you have been maybe treating your body in a different way, not being consistent with the way that you're eating, it can kind of mess up your hunger and fullness cues, make you not hungry at all, make you hungry all the time, both. So tailoring your taste to foods that are more nutritious for yourself, so having kind of a wide variety of foods, meeting all those food groups, or some programs call them exchanges, basically incorporating starches, vegetables, proteins, fats, dairies, fruits, everything into your diet, and embracing size diversity. So again, recognizing that people come in all shapes and sizes. Levels of care. So inpatient is going to be for the most severe cases. So they are not medically stable. They might have vital signs. So when we talked earlier about these physical risk factors, when you get dizzy from going to sitting to standing, it's called orthostasis. And so a lot of places will take somebody's blood pressure when they're laying down, when they're sitting and they're standing, to see if basically your body's working a little bit too hard, and that can cause that dizziness. They're finding that there are lab findings that are, we talked about phosphorus levels, potassium levels, anemia, so your iron levels, your thyroid, your white and red blood cell count. So all of those things are really important things to look for in order to find out what level of care somebody might need. And they are potentially psychiatrically unstable. They might have suicidal ideation, not able to contract for safety. We would definitely need inpatient level of care. And also if they have complications such as diabetes, where they need to be monitored much more regularly by medical professionals. Residential, so the patient's more medically stable. doesn't require that intensive medical treatment, but they are still psychiatrically impaired and unable to respond to an outpatient level of care. So either going in during the day for partial hospitalization or in any kind of outpatient treatment. And that is Renfrew's residential site in Philadelphia. It's a very beautiful campus. Partial hospitalization. So the patient is medically stable, but the eating disorder is really impacting their functioning. They need a daily assessment. They are psychiatrically stable, but they're not able to function normally for social, educational, or vocational situations. So this might be that they engage in daily binging and purging, daily restriction, and very limited food intake, or they're engaging in other behaviors that are really daily controlling their weight. And when somebody were to move to intensive outpatient or outpatient, they're medically stable, they don't need medical monitoring, they are psychiatrically stable, and they might be engaging in some of these behaviors, but it's not completely making it impossible for them to be able to function in normal social situations, education, and vocational situations. Okay, the treatment team. So the most important aspect of the treatment team is that each person has a really crucial role, and it's really important that you work as a team. There are so many health risks that go into this. Obviously, it is a feeding and eating disorder, so there is a lot of dietetics that go into this work. So a physician or a primary care physician can help with kind of medical clearance and monitoring somebody's medical state. The therapist, individual therapy, family therapy, couples therapy, and group therapy. The dietitian, tailoring an individual meal plan for that patient's needs. So identifying what that ideal body weight is based on that individual patient's needs, identifying a meal plan that's going to have adequate nutrition for that patient. Psychoeducation about food, about myths about food. A lot of people feel like, it's healthier to just completely take out carbs or starches, but the dietitian really has a crucial role there to be able to provide psychoeducation about what starches do for your body. Psychiatric provider for medication management. So nurses and psych techs, so those will definitely be people more in the inpatient, potentially in the residential level of care, not in any kind of outpatient, but medical monitoring, administering medications, and then psych techs might be looking for meal monitoring or movement monitoring. So there can definitely be times, especially in the inpatient level of care, where you have to be constantly watching patients to see if they're doing these kind of micro exercises. They might be doing little kind of like push-ups on their seat, jogging in the shower, which is incredibly dangerous and is a slip risk. So sometimes psych techs are there to be constantly kind of monitoring to ensure safety. Obviously the patient, so buy-in for programming is super important, assessing for motivation, and hoping that they are very, very honest and disclosing things to staff. These are really secretive issues and a really secretive illness, and a lot of these behaviors are things that people are doing in secret. And so the more patients are honest with staff and letting them know everything that's going on, the better able we are to help them moving forward. And patients, family, and support. So again, they can be with us and we can be monitoring them, but when they go home, they need to kind of continue working on all of these behaviors. So there might be meal monitoring, kind of relapse prevention, all of that. Okay, so types of eating disorder therapy. So these types of therapies are in a lot of different places. Some places might do an assortment of a few of them. The most important thing is that you're doing evidence-based treatment. So we really want for the treatment that we're delivering our patients to be researched, to be proven that this is something that's going to work for them long term. So that's kind of the most important thing. So acceptance and commitment therapy. So it's focusing on changing your actions rather than your thoughts and your feelings. So identifying core values, committing to creating goals and fulfilling these values, encouraging patients to detach themselves from emotions and learn that pain and anxiety are a normal part of life. The goal is not to feel good, but to live an authentic life. And through living an authentic life, people find that they start to feel better. Cognitive behavioral therapy or enhanced cognitive behavioral therapy. So that will be a short-term symptom-oriented therapy focusing on the beliefs, the values, cognitive processes that maintain the eating disorder behavior. So modifying these distorted beliefs and attitudes around weight, shape, appearance. Cognitive remediation therapy is developing a person's ability to focus on more than just the one thing. So it targets the rigid thinking patterns, that kind of black and white thinking that somebody might be having, and to try to find more of that gray area. Dialectical behavioral therapy. So it has been proven for binge eating disorder, bulimia, and anorexia. So so DBT really believes that the most effective place to begin treatment is with changing the behaviors, focusing on developing skills to replace these maladaptive eating disorder behaviors. So mindfulness, better interpersonal relationships, regulating your emotions, distress tolerance. And again, DBT is something that was originally created for borderline personality disorder, which I will say is often a very, there are a lot of people who have borderline personality disorder or traits of borderline personality disorder that have eating disorders as well. So it can sometimes help with that personality disorder part as well. Family-based treatment. So this is kind of that Maudsley method, if anyone has heard that before. So this is a home-based treatment, and it's more effective for adolescents or somebody who is completely dependent on their loved ones. And it promotes weight restoration by monitoring very closely. And interpersonal psychotherapy, so that is to really just focus on the relationships that somebody is having in this interpersonal context, and building those healthy relationships and improving the interpersonal function and how that can be linked to symptom reduction, because again, these are very secretive illnesses. And psychodynamic is basically finding out the root cause of these eating disorder symptoms and how they might be influencing someone. Okay, so individual therapy approaches. So this is, again, this can be in any level of care, but I wanted to target this towards kind of outpatient settings. So motivational interviewing is super, super important. So motivation is going to go up and down all throughout treatment. So it's going to fluctuate, and sometimes this can be, just a huge part of treatment is just finding, sustaining that motivation and finding the value systems that are helping to motivate somebody towards recovery, and the value systems that might be linked towards the eating disorder and encouraging the eating disorder. So that could be thin privilege and thin ideals. That could be really driving this eating disorder, and a value that's really conflicting with maybe a value system of having close interpersonal relationships if they're avoiding their friends, and the way that the eating disorder values and their own values are conflicting is a major part of that. Okay, so the kind of cognitive behavioral approach that that's really kind of a focus of my work is interrupting the eating disorder behaviors. So the food restriction, exercise, the binge eating, the purging. So it might be trying to prevent them from engaging in these behaviors using supports or having them be in an inpatient or residential level of care. Definitely movement and creating a meal plan with a dietitian is super important to add consistency, so there's regulation as hunger and fullness cues. Reframing these unhelpful eating disorder related thoughts, kind of targeting those core values and noticing the way that they might be encouraging those eating disorder symptoms. Exposures, So exposures are big, but there's something that you need to do kind of a little bit later on. So body image exposures and exposure to fear foods. So somebody's first day in treatment, you're not going to give them, their most feared food. You want to ease up to that. So it's that kind of, gradual exposure. Planned binges are when you take a food that somebody usually binges on, again, a little bit later in treatment, and you give it to them in a closed setting to be able to eat it and listen to their hunger fullness cues. Mirror, so a lot of body checking happens when somebody's active in their symptoms. So definitely trying to look at parts of your body and describe them just objectively, non-judgmentally. So I have 2 eyes, they are green. Just kind of looking at your body in that way rather than judging it. Body tracing is when you kind of put maybe where your head, your shoulders, your hips, your legs, where they start, and somebody draws what they feel like their body looks like, and then you actually trace them over that and notice the usually huge discrepancy. And again, that kind of links into that body dysmorphia, what they think they look like versus what they actually look like. And then other fear experiences, so eating out, trying on clothes, taking them actually on these experiences can be really important. And again, teaching more adaptive responses to these uncomfortable situations and emotions that are increasing these urges to use these eating disorder behaviors. And with that, also the substance use behaviors or potentially the self-injury behaviors, also trying to teach more adaptive responses and adaptive skills to be able to mitigate those behaviors. Skills training, so mindfulness, radical acceptance, tolerating the full range of emotional experiences. We need all of our emotions. They are all there to teach us something. So it's really important that people don't come into therapy trying to just not feel good anymore, but rather to be better at feeling. And working on all of your other diagnoses that are kind of linked in with that anxiety, depression, substance use, trauma work, and establishing a plan for relapse prevention, especially with including the treatment team and your supports. So just a little bit about adolescents and that difference. So family support is really crucial. So attending family sessions, multifamily groups, support groups just for the family, family meals. So you actually have a meal with the family and model appropriate conversation topics. And including non-family members, so peers, teachers, coaches, religious leaders, family and friends. So I know I've done a meal with a patient that brought all of her friends from her dance team. So it was about 12 dancers that were in a room having a meal together because every night they had practice. And those were the people that she had meals with every night. So yes, we did have family meals, but it's also important to extend your definition of family because that doesn't mean that it needs to be the biological family. It can be people that are really big supports for that person. A lot of case management and collaboration with the school, so potentially having supported lunches with a staff member, a buddy system, having breaks to have snacks throughout the day, and potentially making a shift in the schedule, so people having half days at school to attend programming or having a leave of absence. The late summer months and breaks. So there is a phenomenon in eating disorder therapy where people tend to really increase the amount of support that they get during summer and during winter break. We try to kind of fit in treatment around an external schedule. So really just trying to look at the long-term positive outcomes to just getting treatment when you need treatment rather than these short-term negative consequences of, this doesn't really fit with my school schedule or school's starting in a week, so I should probably discharge early from treatment. So really just trying to have a lot of psychoeducation for both the parents and the children to be able to recognize the effects that this eating disorder is going to have on them, with concentration in school, with their friendships, with was isolating from friends, and that going in for treatment may not fit the school schedule, and it most likely will not fit the school schedule, and just to try to incorporate that into treatment. Okay, so we just have a case example, and then we'll move into the Q&A. So this was a 22-year-old mixed-race female with OSFED, or other specified food intake disorder, food eating disorder. So she had a sub-threshold for anorexia, binge purge type, meaning that she was at a healthy, according to BMI standards, body weight, but had all of the symptoms of anorexia nervosa, and with the binge purge component to it. So usually restricting all day and then binging and purging at night. And she also had a diagnosis of bipolar disorder. Levels of care: medical inpatient hospitalization, residential, partial hospitalization, intensive outpatient, partial hospitalization, intensive outpatient, and then outpatient. That was not a typo. So we ended up having to step her back up in levels of care and then step her back down again. That's something really common that happens. Again, when that motivation's moving up and down, that symptom use is moving up and down, that's something really common. Patient strength: she was really open and honest with us, high motivation towards recovery, really supportive work environment in particular. She was really outspoken in groups and individual sessions, and she grew really meaningful connections with her peers. Some barriers to treatment: definitely some financial concerns, some strained family relationships, some substance abuse that started kind of peaking during treatment. Definitely struggled with the racial stereotypes around who should have an eating disorder and what an eating disorder looks like, which really impacted her body image in particular. And she had a lot of isolation from friends when she was in the heat of things. Some important aspects of her treatment approach: so medication management was crucial, trying to monitor and stabilize that those bipolar symptoms and those mood fluctuations. Again, motivation fluctuated all throughout treatment, so there was a lot of work on trying to identify her value systems and seeking that internal motivation because of her values, rather than I have to get treatment because then my family will be mad at me, or I won't be able to work as well at my job, and so I could lose it, and then I could be homeless. We wanted to find those internal motivators. Symptom swapping: so this happens a lot. It's kind of like playing whack-a-mole, it feels like, with the patients and with the staff. So she was exercising as times for compensatory behaviors and purging, a lot of restriction without any binging and purging. She started drinking quite a bit throughout and smoking marijuana throughout treatment, engaging in some self-injurious behavior as well. And so when we kind of started to get one symptom kind of down, another one might pop up. And that's something that sometimes happens. So a lot of it is kind of getting to that baseline. What are the emotions? What is this distress and this emotional experience that you feel like keeps leading to these behaviors that are fueled by this emotion? And how can we limit the avoidance of feeling that emotion and just trying to experience it altogether? So she had lack of supports in treatment. So we included family. Again, family is not biological family. It's whoever is a meaningful support for you. So we ended up including her boss into treatment. So she worked for a very small store, a company, and her boss ended up coming to multifamily groups, sessions with us to figure out ways to support her. And this is the person that she was around almost all day, every day. So again, this idea of family really needs to be broadened to who are the people that you're around all the time and who can help support you with this. And searching for mixed race support groups, which was incredibly difficult to find. Yes, so this was a really, really hard thing to find. She felt like she did not identify as Black and she did not identify as white. She didn't feel like she fit into either one of those groups. So trying to find something that fit more of her identity was actually more of a struggle than I thought. We did end up finding something specifically targeted towards drinking, as that ended up starting to become more of a problem later on in treatment. So a lot of restructuring of those automatic thoughts and the way that your core belief system can kind of influence those thoughts. So I like to think of the core belief as kind of the root of a plant, and all of the negative cognitive thoughts are kind of all of those leaves underneath. So if there's root rot in that plant, the leaves are not going to be healthy. So we really need to get to that core belief system and help rephrase that to be able to help that person to have less frequent or less severe negative automatic thoughts. And again, with a lot of work with a dietitian, again, it's a huge team approach, incorporating more of these starches, these fats, and then we ended up including a candy planned binge with her in order to help overcome that fear. Okay, Q&A.
Awesome, Ms. Lamb. Thank you so much for the presentation. We had a lot of questions come in, so we can only get to a few of them, but many folks wanted to know if you could quickly go over RFID again and just explain what that is.
Yeah, so RFID, when you are looking at RFID, it looks a lot like anorexia. So somebody will be refusing food, will only eat certain food groups, will have only very small portions of food, will skip meals. But the basic difference is the intention behind it. So the people who have RFID, and again, they're usually young boys, and a lot of them are on the autism spectrum, they are fearful not of gaining weight, not of being fat. They are fearful of the texture of the food, that it feels uncomfortable and weird in their mouth. They are fearful of choking on that food. So if they only eat a little bit, maybe they won't choke, or they're fearful of vomiting. So it's never that fear around body image concerns. It's only the fear around the food itself and the way that it might hurt them or impact them in some way.
Great, thank you. And another concern comes along the way of self-harm. So the question is, does the person always want to lose weight when they restrict food intake, or could this be a way to harm themselves?
Yeah. So to meet that diagnostic criteria for kind of the big ones around anorexia nervosa or bulimia nervosa or any of the kind of sub-thresholds, there is that fear of weight, of getting fat, of gaining weight, of being a certain body image. So there is going to be that concern there. However, I have absolutely, especially with somebody who has a history of sexual assault, sometimes it's a punishment type of practice where it is a form of self-injury by starving themselves.
Got it. Thank you. Another question was around just where we are with regards to the pandemic. So given the current health crisis, have you noticed any trends in disordered eating or any uptick in that?
Absolutely. Absolutely. Yeah. So as I mentioned before, this is a very secretive disease, right? You're, not meeting up with friends because you don't want to eat around them. You're maybe binging in secret and purging in secret. People are so much more isolated right now. So they are engaging so much more in their symptoms. One thing that has been really incredible is that almost every eating disorder facility and almost every private practice physician is extending into virtual platforms. So we're able to capture people in their homes, but with the increased isolation, there is definitely an increase in symptom use that we're experiencing. Definitely an uptick in referrals that we're getting for sure.
Great, thank you. So I just want to take the opportunity to thank you for the presentation. We are running out of time, but I just want to make sure to thank you and thank everyone else for joining as well.
Mm-hmm. And again, if anyone has, I know there were a lot of questions, but if anyone has more questions, they can feel free to email me. I post a lot on my social media as well, because that's kind of the nature of being a therapist these days, it feels like. So you can always reach out to me on there or over email if you have any other questions.
Awesome. Well, just everyone, thank you again for joining. The slides will be up on the CTAC website within the next 2 to 3 days. In addition to the recording for today's webinar, we invite you to join us for any upcoming events, which can be found on our CTAC website. If you have any other questions or concerns, please contact us at ctac.info@nyu.edu. Thanks again, and please make sure to fill out the feedback survey for today's presentation. Take care, everyone.